Welcome to the North American Drug Checking Summit. I am Brandy Wilson. I will moderate this panel today. I'm the ED at Chicago Recovery Alliance, and a few things that we want to go over before we start is this is a brand new platform for us to be using, so it very likely may have some hiccups, not functioning properly, and potentially a lot of user error. So bear with us, but we still hope it is informative and engaging. Another thing that we at CRA want to talk about real quick is over the weekend we lost a longtime member of CRA, Ponytail Steve Kaminsky. He was found in his house on Friday, or he was found on Sunday. So for this week and during this summit, um, please excuse all of CRA for not really being 100% this week. We felt that the conference needed to continue as the drug checking program is something that Steve utilized regularly and would probably be deeply frustrated with us if we postponed it. So we just wanted to make a note that we are struggling a little this week, so don't expect us to be 100%, please. But yeah, so thank you everyone for coming, and each presenter will have somewhere between 6 and 8 minutes, and I will give you a soft little nudge when your time is coming. And then please drop your questions in the question box, and we will get to them towards the end. I will share my screen and we will start. Okay. So welcome and thank you for joining us for the Alliance for Collaborative Drug Checking Real-Time. This is our second conference, and we are going to discuss results, trends, and lessons learned through all of the great collective work of the drug checking programs that exist. And then Eliza is up first, and I have to do a different screen share.
Sorry, Brandy.
It's okay. It is okay. Well, my mic's not on?
You are.
Oh.
Yep.
Oh, this is good. Okay.
Very harm reduction. Like
All
just
day.
being on brand. It's fine.
So on brand. We're just so on brand right now. Okay.
But I can start. Wow, you did it. Amazing. Hi, everyone. So I am going to just give you a brief overview of our drug checking work, which unfortunately has been on hold since COVID. So since San Francisco went into shutdown in March, we have not been able to use our lab. which was our primary collaborator to do drug checking, because they were sort of what was it called? Like reassigned to doing COVID work. And so we essentially were in operation for exactly a year. So I will sort of give an overview of what our project did from March of 2019 to March 2020. And it says here that these slides were made by myself and also Sharon, who was our primary doctor who worked at the lab, who did the analysis of our samples. So she's not with us on this presentation today, but pretty much this work couldn't have been possible without her. Brandy, can I forward the slides or do you have to do it?
I don't know, but if you just tell me next, I'll do it.
Oh, I can do it, actually.
Okay.
Or I just pressed something and it went forward. So our project was not a real-time drug checking project. So just to get that out of the way, it was a little bit different. We worked in collaboration with 3 syringe access programs, harm reduction programs in San Francisco, the Homeless Youth Alliance, the SF Drug Users Union, and Glide Harm Reduction to collect samples from folks who use drugs, who submitted samples usually of just residue or in some cases partial pieces of pills, and in some cases full samples of drugs that they were concerned about. And then we would bring them to the lab and they were analyzed using LCMS. Okay, next slide. I guess it doesn't let me do it.
It has a lag. Oops. Did it work?
No. So while we're waiting to go forward, so essentially the results of our project were really most useful, I think, because it wasn't real-time drug checking. There wasn't the possibility of having the real-time conversations with folks about what was in their drugs. But what we were able to do was we ended up thinking of the project more as like a surveillance pilot project, where we were getting a little bit better knowledge of sort of emerging drug irregularities, or in some cases kind of confirming what people suspected or knew about their samples and the drugs that they were using. So that's sort of how we ended up looking at the project. We were able to get really high level accurate results using LCMS, which was really great. And so in terms of kind of pros and cons, the con obviously not being real time and the pro being really accurate and detailed data about the drug samples. Okay, next. One of our samples, big one. Next slide, Brandy. And next, yeah. So we collected samples from folks. That's a picture of one of our staff people at one of the sites being really excited about getting the kits. We labeled them, we put them in those little plastic sample collection containers and then in these biohazard bags just to essentially make it look more official. And We would do a little report with the person. It was pretty short. It asked a variety of questions about their experience with the sample, and some kind of basic location data in the city about where it was purchased, and most importantly, kind of what it was purchased as. So people, so if something was purchased as methamphetamine and they want to know what it really was, then that's how we communicated the results. Okay, next slide. We documented everything in this ACDC sample analysis log where we entered the information. This was available to myself and our lab folks at the lab. So we would enter all of this per sample. Go ahead. I won't get too much into the science. This is definitely Sharin's slide, but this is the technology that she used to analyze the samples. They were run through LCMS, and then she did the all the analysis of the samples. We ended up kind of dividing things per sample into kind of a major component, a minor component, meaning there was enough of something in it to possibly have an effect, and then trace, which was under 100 mg. There was lots of stuff in all of the samples. You can go to the next slide. I think it's the results slide, and then I'm probably coming up on my 5 minutes. Go ahead.
You're at 6, Eliza.
Okay. Go ahead. Go ahead to the results slide. Yeah, go ahead. One more. So the way that we communicated the results to folks were through these results sheets that we would post at the syringe access sites where we collected samples. It was really kind of a work in progress to communicate the results the way that we did that, where we would list the code on the sample, which people could match to a little card that they got, kind of like how we used to do HIV testing. So it didn't have names or anything. There was no names ever collected. And so people could match, like if they had the little card that said dope 04, that they would know that that was their sample. We would do a square for sample profile, kind of where it was purchased. We would never give direct actual location information like an address or an intersection, but more neighborhood. What it was sold as, and then a brief summary of what the person's experience was, what it ended up being. So we would list major components and then things that were trace, and then sort of an explanation of what that could possibly mean for people. On the back of the sheets, we would do the breakdown from the LCMS in terms of the detected compounds. And then a description of what each of those things were, kind of explaining which things were byproducts from processing, what was possible cross-contamination from having multiple drugs in your, pocket or Altoids box or whatever. And what might have been.
He's at 8.
Okay.
Oh.
Sorry.
Right. I thought.
It's okay.
Sorry,
and then
I did
the last. Go. All right. Go ahead. You can show the last slide maybe, and then we can end. So essentially, what we found was basically not a lot of contamination of our drugs. The fentanyl was largely just fentanyl. The black tar was black tar. The cocaine was cocaine. Methamphetamine was methamphetamine. Very little fentanyl contamination in other drugs. Okay. Lots of successes and challenges.
Thanks, Eliza. I'm sorry that was messy at the end.
It's okay. It's okay. And of course, available if people have questions.
Oh, look at us go. Okay, we'll go back to my screen. All right.
Good.
Sarah and Claire from A-Hope, you are up.
Right. I got a front tooth missing, so if I can't understand me, let me know. I picked up MMA over COVID, and I'm not very good at it. So anyway, so you can go to the next slide. I'm going to be really quick. So I feel bad that because Eliza could have some of the time that I was going to use. Just a quick overview about programs. A-Hope has both fixed and mobile sites in Boston. We reach about 8,000 people a year. Almost our entire population base is homeless or unstably housed. We've been doing naloxone and Narcan distribution since 2006. We do a lot of drug user health services, just like everybody else, I think, on this call, everything from HIV testing to harm reduction case management to referrals to care. Our drug check is kind of in its baby phases still. So we started do point of care drug checking in March of last year with the MX908, which is a high pressure mass spectrometer. I always look at Claire because I'm like, I don't think I'm going to pronounce this correctly. We also were able to do kind of backup testing with fentanyl test strips. And we also have benzo test strips as well. We recently, as in like recently in the last couple of days, obtained an FTIR, which we're really excited about. So we're starting to kind of get our feet wet with that. And get more comfortable with it and use it alongside the MX908. But we were also able to kind of work with Abby and Tracy Green to throughout the year to do some side-by-side testing just to kind of double check on some of the results that the MX was giving us and to try to get a broader scope of what samples we were collecting and what was in them. Go to the next slide. So this is just a kind of a quick visual of our drug checking results just between April and March. Can you close that for me? Yeah, sorry, people are loud. It's lunchtime here. Everyone's really loud. Like Eliza, we had to shut down in March our drug checking piece of things just as we moved all of our services outside, and we really kind of drastically had to scale back some of the activities that we did. So there's a large amount of time there where we just weren't really using the MX kind of sporadically, but we've just recently started kind of become up and running again with drug checking. So that kind of sucks not being able to provide that service to people. Unsurprisingly, most of what we are finding, which is sold as like heroin or dope or brown, is primarily fentanyl. Very few times have we gotten samples that are described as like brown or dope or heroin. Is actually heroin. So, which is again not surprising. I mean, I think we knew right off the bat that fentanyl is pretty pervasive in the drug supply out here. It should be noted that the drugs that I chose to show here, it's really just what we collected that were described as that, and it doesn't necessarily describe. We could have done like 2 or 3 other slides on like all the samples that were described as meth or the samples that were described as coke, but they weren't as interesting. They mostly came back as meth and coke. Like so, there really wasn't a lot of like quote unquote contamination. Fentanyl within the meth supply, but we did find a whole lot of shit in things that were brought in as dope or heroin. Do you have anything to add on that?
I don't think so. I think that sounds about right.
Right.
Yeah, so not only was fentanyl found in almost every sample that was described as dope, we never really ever saw heroin. I think like a handful of times over the course of a year. Yeah.
What's interesting too is that like I think that 1 or 2 times that someone has come in and I don't know if it was for drug checking or something else, but they were like, man, actually it was drug checking. Mm-hmm. Came in and he's like, man, I had this really terrible reaction. I like broke out in hives. It's really hot and itchy. And then we tested it and it came back as heroin. And he was like, what? It's like it's interesting that like people are actually describing like adverse effects from taking heroin, whereas like our old school people would murder someone to get their hands on real heroin. So like this has been going on for a long time. We're not surprised that it's primarily fentanyl. The MX, it should be said, is, we'll have a longer conversation about the MX and how it works and how reliable it is. But it did, give us a couple of hits on like acetylfentanyl or butyrylfentanyl, benzylfentanyl here and there. But for the most part, it's just straight up fentanyl. But yeah, I think that's it for this slide for the most part. Yeah, you want to go to the next one? The key takeaways, which is what I already said, was, there's a lot of fentanyl in our drug supply, which is not surprising, but I think that like the scope of it and the lack of any heroin hits has been was a little surprising at first. It'll be interesting to see as we move forward and we are using the FTIR kind of in tandem with the Annex 908, whether or not like we get a little bit more information from the supply or whether we're finding things that are different. So really looking forward to the next couple of weeks to months and seeing what we're able to find with this new machinery. We're reaching people that we traditionally weren't able to reach in the past, which I think was one of the reasons why we started the drug checking program, or at least that's really kind of like what we lied to our funders about in order to get it. So like people are coming in who are sniffing or snorting or smoking, and that was really cool because these are folks that like we can get naloxone to, and it was able to like break into communities of color that we normally weren't able to kind of reach and open up and create new relationships. So that's really exciting. I think everything else we covered except that we found is really important, and things that Tracy Green also says pretty frequently is user experience, like people's description of like how the drug felt is really a key data point, and I'm hoping that as our volume goes up over time, we'll be able to kind of make more sense of that and sort of make something that we can give back to people that will be a little bit more usable. So finding a good use for that information moving forward. I think that's it. Anything else?
Yeah. No,
Yeah.
it's perfect.
Super quick. Any questions?
Oops. Next slide. Okay. Was that what you all had?
Yep. Weird. Yeah.
Okay. Thank you so much. Now we have British Columbia Center on Substance Use, Seth Long.
Hello?
Hello.
Can you hear me okay?
Yes.
Okay, perfect. Sorry about that. Hi everyone. My name is Seth Long. I am a graduate research assistant with the drug checking team at the British Columbia Center on Substance Use. So thank you so much, first of all, for allowing me to be part of this conversation and to speak about the drug checking project that we are collaborating on with the different organizations at various sites in British Columbia. So today I'm going to briefly talk to you the following topics: the BC drug checking project, the population served by the project, the different technologies, and most importantly, some of the emerging trends from the community drug checking project that we're seeing here in the BC unregulated drug supply in the context of the ongoing overdose epidemic. Next slide, please. So the BC-CSU drug checking project is funded by a Health Canada Substance Use and Addiction Program grant that allows the BC-CSU to implement and evaluate a drug checking pilot in British Columbia. So the project is in collaboration with regional health authorities, community-based organizations, and various levels of government. In BC, like several models of drug checking services exist using different technologies at point of care. However, the main technologies used for this project are the FTIR machine and paired with fentanyl test strips. We also recently introduced benzodiazepine test strip as well as a result of community alerts of benzo adulteration in the drug supply. Beside point of care drug checking services, we also partner with various labs to implement confirmatory testing using QNMR, GCMS, and LCMS with a small sample to ensure accuracy. As for the confirmatory testing protocol, once service users consented for their sample to be sent over for confirmatory tests, a small portion of the sample submitted for drug checking will be collected and packaged and sent off to our partner lab for confirmatory tests to be completed. In terms of the population served by this drug checking project, there are two main populations that we're providing the services to. One is the people who use in community settings, and the other people who use recreationally in music festival settings. However, data present in this presentation only focuses on the prior population, which is the population of people who use in the community settings. So I have selected 3 key findings to share with everyone from data that we collected between June 2018 and December 2019. Next slide, please. So first, as you can see here to the left corner of your screen, is the trend that shows benzo positive samples in expected opioid drug sample at point of care using benzo test strips. So of note, expected drug means client purchased drugs, and expected drug are reported at point of care when service users submitted their drugs for drug checking to drug checking technician. We can see here that it was only in April 2019 when we started to see benzo in opioid sample from samples submitted for drug checking. And the frequency of benzo adulteration increases over time. And with the exception of this trend, we have data, more recent data until May 2020 or during COVID. So with over the last couple of months, we also see a spike in benzo adulteration in drug supply as well. So these are just some, using confirmatory testing, these are just some of the benzo analog that we found in this sample. So to your right-hand corner, we have the trend in fentanyl concentration among positive fentanyl sample using fentanyl concentration quantification model developed using point-of-care FTIR results and the corresponding confirmatory testing QNMR results. So what I'm showing here is the monthly median fentanyl concentration. As we can all see here, a declining trend in median fentanyl concentration is observed from a peak of 10% in August 2018 to a low of 5% in August 2019. So this trend would need to be monitored further with recent data to evaluate whether this trend will persist. So lastly, to the bottom of your screen, we have synthetic cannabinoids contamination in expected opioid drug sample. For this period, 16 samples were found to be contaminated with the following synthetic cannabinoid using results of confirmatory testings. FTIR failed to detect the sample compound in more than half the sample at point of care, likely due to the technology's detection limit and its sensitivity. With these potent substances found in this drug checking project, it stresses the importance of drug checking services to service user in this setting. So as a reminder, these results only accounted for data collected until December 2019, except with the exception of the benzo result that we have until May 2020. So we're currently working on some of the some analysis that we would see more recent trends to look at how COVID may have impacted these trends. Next slide, please. So some of the key takeaways from this findings include the fact that the increase in benzo adulteration speak to the need for benzo test strips at point of care. And additionally, community engagement is a critical component in the design and implementation of drug checking services in this setting. As an example, as I mentioned earlier, community members were the one that alerted us about the benzo adulteration in the community drug supply. This kind of led us to implement the use of benzo test strips to monitor the frequency of benzo adulteration in a drug supply over time. And fentanyl quantification is valuable to capture and monitor fentanyl concentrations in the unregulated drug supply, particularly in a setting where there is fentanyl saturation in the market. And lastly, the emergence of synthetic cannabinoid contamination in a drug supply kind of stresses the importance of using confirmatory testing to complement the limitations of point of care technologies. Although we only focus on these key findings, there are many others that we have looked at. Next slide, please. So this is all I have prepared for this presentation, but I want to acknowledge and thanks, first of all, the service user who submitted their sample for the analysis. And I also like to things, the ACDC organizing committee, our funders, the BCCSU, especially the drug checking team, and our partners for making this work possible. We also recently launched our website too. So if you have more if you want to know more about the drug checking project and more recent data on drug checking project in BC, you could visit our website at drugcheckingbc.ca, or you could send us an email at drugchecking@bccsu.ubc.ca. But I'm also happy to answer any question you may have in the chat as well. Thank you.
Thank you. And now we'll go to Brandeis, and Brandeis will be discussing their drug checking strategy.
Hi guys, either good morning or good afternoon, whatever time zone you're in. So incredibly grateful to be here today with all of you. So we do things a little bit differently. We are funded by the state government through the CDC, or vice versa. And we are doing this like in an academic institution rather than a harm reduction agency or a health agency. We have a very interesting team. So it's myself as a project manager. I manage all of our community partner drug checking. Becca Olson is another project manager we work with, and she manages all of the police drug checking that we do, and I'll talk more about that in a bit. Benjamin Hominskas is our research assistant, and before I had drug checking wizard because he's an absolute genius with chemistry. We have Rachel Whiteman, who's a clinical toxicologist that we have on call, and as was mentioned before, we have Tracy Green, who is our principal investigator. So we have a really diverse team, and we're very lucky to be able to call on different people for different tasks. And I think one of the best parts about our study is the fact that we can literally call a clinical toxicologist and be like, hey, we just got something really weird in a weird combination. And she can give us very, very accurate results of what that'll do to a human body. Next slide, please.
Is that the right one?
Yes, perfect. So again, just as background, this is federal and state funded. So we initially started in a small community in Massachusetts called New Bedford, the fishing community on the South Shore of Massachusetts last spring. And samples we collect are collected through collaborations with community organizations, some of whom are here today, so thanks guys, as well as police departments. So when we are doing drug checking, community organizations, they are usually donated drug detritus, so like once-used cookers, cottons, and baggies from participants. Whereas at the police department, we're collecting samples that came from seizures from arrests, collections from overdoses, and then just like stuff they found. So we have several current partners. We have Seven Hills, who's a behavioral health agency in New Bedford, Massachusetts, kind of been everything but the syringe exchange. You can thank their mayor for that. Healthy Streets in Lynn, Massachusetts, which is a SEP. Manic Community Health Center, which has an SAP associated with it. Obviously AHELP as well, but they're just not a formal partnership, MOU, BS next. I'll get into that. The New Bedford Police Department, and we have several other agencies and municipalities that are coming on board. We use 3 different technologies. So we use the BTNX fentanyl test strips, the Bruker Alpha FTIR, and we are also partnering with Arrowhead and drugsdata.org to do confirmatory testing. So I feel like it's important in this space to kind of talk about our relationship with the police departments we work with. So we work with these police departments, and we've developed MOUs with each of them to essentially say like they won't arrest us or our participants for having drug checking samples or bringing checking samples to us. So it's through those partnerships that we're really able to do this work. So it protects us as the researchers, and it also protects participants from carrying their samples to us. There is a particular desire from the from our funders for there to be a relationship and with police, so between public safety and public health agencies. So it's through that we are doing this work. So next slide, please. So I'm just going to talk about our trends from April to June of this year. We have been continuing to do drug checking despite COVID-19. We have a couple of restrictions in place. So Brandeis's institutional review board was basically like, you can't talk to actual humans to do drug checking. And we were like, cool, how about they just drop it off and we'll just check them there? And they were like, that's fine, because it's not human subjects. So we are physically going out into different community spaces right now, and our community partners are collecting those samples for us, and we are testing them there. We're able to give some results back, you know, on like right in the moment, but we usually publish them like a week or two later, depending on when we got confirmation testing from drugs data. So most of the samples we've collected in these couple of months so far have been in the form of cookers. One big takeaway is we are beginning to question the validity of BTNX test strips for fentanyl. As I said before, our research assistant is incredible, and he has done a whole analytic look at what the BTNX test strips are picking up, what the FTIR is picking up, and what the GCMS is picking up. So, and he is presenting later this week, so stay tuned for that. But kind of the moral of the story there is, at least on our end, they are not picking up as much as we would like them to be. Many of our samples recently have had tramadol as an adulterant, which, you know, is a non-opioid pain medication, but it also it has those similar effects as an opioid, so pretty dangerous. There's been, obviously, as Sarah said before, a strong presence of fentanyl and also precursors and degradants for fentanyl. So phenyl 4-AN-PP, 4-AN-PP, and 6-monoacetylmorphine. We also have a wide variety of cuts and filling agents. So the number of cuts that we have gotten in samples in the past couple of months could take up easily 5 slides. Next slide, please. So these are all the actives we have found in samples just from April to July of this year. So we've tested 105 samples, and of those samples, we've had 45 have fentanyl in them, but then as you can see, 13 had tramadol. And so we kind of grouped on the right side all of the opiates and degradants. At the bottom left corner is stimulants, so cocaine and methamphetamine. And then in the top left corner is everything else. As you can see, there's a pretty wide variety of adulterants. This is not even including any cuts. This is just literally all the active ingredients we found in things. There have been some pretty rough combinations. So we've been getting a good chunk of samples, for instance, of cocaine with phenacetin, which is an off-the-market pain medication because it ridiculously increases liver toxicity. But people are still putting that in samples. And then, of course, we had a couple of different random little ones, like one with nicotine, one with CBD, and a whole bunch of chemicals that I can't pronounce because I was a theater major. Next slide. So the too long didn't read of this is, are people getting what they're looking for? So and keep in mind there's a very small N here because a bunch of the samples we got, we either didn't know what was in them because they were found, or people said it's dope. And, unfortunately on our end, we can, assuming that dope means heroin or fentanyl is kind of a slippery slope. So we just didn't even include them. So of those 41 samples, 66% of them contained, at least in some part, the sample it was bought, or the substance it was bought as. So not a bad thing. But then on the flip side of that, 82% of those samples also contained something else. And so, as you can see on this slide, it's really important for us to be able to break down those samples to see like the different components, and having a clinical toxicologist on staff really helps us to do that, to determine the harmfulness of what people are getting. Next slide. That was it.
Okay, thank you very much. Now we have the Chicago Recovery Alliance and the Alliance for Collaborative Drug Checking, and I believe that is Lydia. She is getting herself together right now. No? No. Little technical difficulties. We're trying to hear her. Then come here. Make sure it's by your mouth.
Oh no, I can't see anything.
Just push the thing. That's the only way you get to do it.
All right, is everyone able to hear me? I don't know. Can you go listen on my computer?
Yes, we can hear you.
Thank you, Nikki. All right, this will be a pretty fast one. So one of the things we often talk about in Chicago, this is old data, it's from 2017 from the Chicago Department of Public Health, but there are very large racial disparities in opioid-related overdose deaths in Chicago. In particular, we see the most deaths in the non-Hispanic Black population. And because of systemic racism and redlining and everything, that often leads to overdoses being concentrated in areas of high economic hardship, which is what this map shows. And that is where CRA often has our mobile outreach locations and a lot of our outreach for this very reason. So when we talk about drug checking and some of the results I'm going to present, the drug checking prior to COVID was done in real time on our mobile outreach vans in these locations. During COVID, we have not been able to have the machines on the vans. We are still able to test items that are dropped off, but it means that we have seen a pretty significant decrease in people being able to access services because it's important that we be able to bring the services to them, and that's been very difficult during COVID. So the machines we use the FTIR, we use the MX908 high pressure mass spectrometer, and we use the fentanyl test strips. So all samples that have sufficient sample size and are of us in a form that can be tested in all three will receive all three tests. Sometimes there's not enough powder and we're not able to use the FTIR, and sometimes when things are liquids, we also aren't able to use it. And so we try our best to have all three, but there's a very few instances where we were not able to run something through all three. Here's the results so far. We've tested 268 samples of dope. I have the results up here, and I'm going to talk about two in particular. So the MX908 for a very long time was miscategorizing diphenhydramine or Benadryl as amphetamine, and so that's why you see that 16% right there. These two numbers should be added together to get the full picture. And what this means for Chicago in particular is that almost all of the dope is cut with diphenhydramine. Diphenhydramine is known to trip false positives on the fentanyl test strips, so we have a fun battle with our results of making sure that we're not reading false positives due to the fact that we know diphenhydramine is in the dope, and knowing that on the MX for a long time it was miscategorized as amphetamine. We also have a certain number of results that have no heroin or fentanyl in them using these tests, and that is where we have been able to use confirmatory testing from drugs data with the GCMS and Notre Dame's Lieberman laboratory with the LCMS, and that helps us figure out what's going on there, because if our 3 field tests aren't able to catch something, but it is in there, knowing the blind spots will make it easier for us to give better results in the moment with participants. And then the last thing I'm going to talk about, one of the advantages of the FTIR is that it allows us to look at cuts. And so that can, again, help us with some of those samples where we aren't able to identify an active. And so the ones I have circled right here are things where we have confirmed that there is fentanyl. They are more likely to have mannitol and quinine in them. And so a very common profile that we will see if something has lactose and mannitol and quinine. And then we are becoming more comfortable with inferring that there's probably also fentanyl in that sample as well if we can't see heroin or fentanyl and we don't get a positive ID on one of the tests. And this is my last slide. I'd like to thank everyone who supports us and all of our partners and our collaborators, many of whom are also on this call. Thank you.
Hey guys, can everyone hear me?
Yeah, we can hear you.
Great. All right, I'm actually going to switch over to my little slides here because I prefer talking to making fancy slides. So I have my little notes over here that I'm going to talk from. Thanks everyone for joining us. Super happy to be on this call. DanSafe's a little unusual in the drug checking world in that we started in the late 90s. So we've been doing on-site drug checking at events now for 2 decades. Focused almost exclusively in the very beginning, focused exclusively on misrepresentation in MDMA markets. And we really still today focus primarily on non-problematic substance users. We're working almost entirely at music festivals and other music events. And so our target population is very different. The challenges are very different. And we have no memorandums of understanding with anyone other than the event promoters that we're working with. And so, yeah, we're sort of an outlier in this. We work primarily along a chapter model. So we have a lot of chapters throughout the United States that are run by volunteers. And this is really, drug checking is really one part of what we do. It's really a larger peer education, harm reduction education, outreach organization. In terms of technology, we use reagent testing as sort of like our primary thing that we use, which works quite well for the substances that we're looking to identify and the misrepresentation that happens within the markets that we're dealing with, with MDMA misrepresentation being almost all cathinones, and LSD representation being primarily non-indoles. Reagent testing is actually relatively useful. We also use the immunoassay strips. We helped with a study that'll be published later this year with professors from CSU Long Beach and UCSF about the immunoassay strips and their efficacy. And we've also been borrowing a Bruker Alpha and have now fundraised for our own. Have not purchased it yet. We're still hoping to find a used one to get a little bit of a price break. And of course, we also partner with Irwin and Drugs Data. So if you want to move on to the next slide there. So yeah, in terms of emerging trends, I want to give a sort of full disclosure here. I'm basically currently blind without events. So historically, we have a really slow season that goes from October to February, where we do very few events in those months, and then we have, from the rest of the year, our summer is incredibly busy, where we test at hundreds of events. But with the COVID shutdown happening just as events would be picking up, realistically, since last October, we have only really been set up at one large event. And so with how quickly drug markets change, right now we're not able to do drug checking. There are no events happening. There is a drive-in event that's happening in Denver that the Denver chapter might be working, but they're not going to be doing drug checking. And so, yeah, right now it's really difficult to say what's happening within the drug markets that we look at. But on a sort of larger sort of meta-analysis, the things that we've noticed over the last few years, one of them has been the spread of fentanyl to non-opioid substances. So we've seen a lot of fentanyl showing up in substances that were sold as cocaine, methamphetamine, MDMA, MDA. And so we're starting to see this trend of the opioids showing up all over the place. Why that happens being the million-dollar question, but that is something that's happening. The other thing that we've sort of noticed is an increase at the speed in which really new psychoactive substances hit. There's a trend within particularly law enforcement to call anything other than the dozen or so drugs that most cops know, they call them NPSs. I certainly don't think of 2CB as an NPS, for instance, but the media talks about it that way, the police talk about it that way. But we really have seen an increase in the speed of real new psychoactive substances, particularly within the cathinone family, which is often misrepresented as MDMA or cocaine. And between 2014 and now, somewhere between 30 and new 50 cathinones have actually hit market. And these are brand new. These are not things that were written up in medical literature. These are really new drugs. And so that's been sort of one of the trends that I think is really concerning, is the speed at which black market chemists are developing and bringing to market new substances is clearly accelerating in my mind. It's clearly happening faster, which means that as drug checking services, we sort of have to learn to be responsive quicker. We can't be as sort of slow to be responsive as we have been historically. And the other sort of really alarming trend is the development of microgram active substances. As prohibition as border control gets better at intercepting packages. People work on developing more potent analogs, so it's easier to smuggle. And so we're starting to see that. And I guess the last trend that's sort of been really concerning is that there are now substances that are being laid on blotter and sold as LSD, whereas historically there was only a tiny handful of those. The DO family was the sort of main misrepresentation. We now have a lot of different substances that are getting put on blotter, including the N-bomb family, which are killing people. So can we move on to the next slide? That image is my favorite misrepresentation image because, yeah, I don't know, DDoS. One of the things that's sort of unusual about DanceSafe is why we're really doing the drug checking. So we're not a data gathering organization. We don't, work with any county governments. It's really an on-the-ground harm reduction service. That's the goal, is to provide drug checking on the ground for people who need it. It also works as a really good point of contact for non-problematic substance users. The people who are coming to the DanceSafe booth are, on a population level, by and large, are not people who are going to needle exchanges. They're not people who are, searching out traditional harm reduction services. So this allows us to reach substance users who otherwise would have no interaction with harm reduction, and often don't even know that misrepresentation is a thing. They have no idea that, the MDMA they buy might not be MDMA. And so drug checking is a really good way to open that conversation, to have these conversations with these users. It also allows us to really push the message to everyone that we're, interacting with, the root cause of these issues, which is, of course, drug prohibition. I really view what we do as anti-prohibition activism. In regulated markets, these issues vanish, and so we really try to push that message as broadly as we can, that there is a solution to this problem. The solution to drug misrepresentation is actually a relatively easy solution. The solution is a regulated, controlled drug supply where people can actually, go through a process to legally sell or purchase or use substances. And so we are always out there trying to push that message. So yeah, thank you for having me on this, and really appreciate that. If anyone wants to track us down, we're at dancesafe.org. And it's so great to see so many of the people that we only really get to see at conferences on this call.
Thank you. And then now we have Fire and Earth Arrowhead.
Well, we're going to see if...
Can you see us? Can you hear us?
No?
Hello?
I can hear you. I can't see you because I have a screen up, but if you don't have slides, I can stop sharing my screen and people can see you.
Well, yeah, you can also try that. We're not going to have a slide. But you can hear us, though.
Yeah, we can hear you.
Okay.
Oh, hi, people in the background.
No video, huh?
Let's see. Are your videos on? Yes, both of your videos are on, so I'm not sure.
We're these, other people.
We're seeing the background of your office.
Our office or A-Hope?
Well, A-Hope. Sorry,
yeah.
We're seeing A-Hope.
Yeah. Oh, now there's some other people. Our IT help.
Try opening your software version and using the camera from that.
Well, that didn't work before at all. Well, let's try it.
Yeah.
So we can't.
The system's really funky. Sorry.
Wait. So we'll try. A second here. Pictures.
No.
You have no Blue Jeans meetings. Calendar not connected. Click here to connect. Oh, yeah. No, not gonna work. Okay. Well.
So we haven't been able to get the software version to work today, obviously. So I don't know how to even.
So you're saying that you're not getting any video. Our video says it's on. Our audio is obviously working. Well,
Yes.
that's
And now we
hilarious.
aren't seeing anything on the screen either.
That's pretty fun.
Andrew, is it possible for you to talk us through your stuff or no?
Sure, we can.
Sure.
Yeah,
We'll just do it audio. It'll be lovely.
God.
So I guess we should have had a slide. Then at least you could have shown a slide. Okay, so the first thing is that if anybody cares to follow along, we put up on drugsdata.org/ACDC. You can see notes for our talk. It's a PDF there. You can.
It's not a slide. So drugsdata.org/ACDC. So, just brief reminder history that Arrowhead's drug testing project was founded in 2001 under the name Ecstasy Data, but last year we renamed the whole project to Drugs Data, and so we have mostly successfully completed that, although, 19 years of history is a little hard to erase, so we're still fixing some problems around that. And while we were originally designed to test ecstasy tablets, we've obviously now expanded to test a lot more white powders, blotter, research chemicals, pharmaceuticals, real and counterfeit, and as of last year's ACDC meeting, a lot more street heroin, including gear like cookers and cottons. Which has been that's probably the biggest change for our lab, is just coming up a different set of procedures for how to handle weird, aluminum gear and cottons and filter cottons. There's a problem with your network.
Can you still hear us? Oh no, can you still hear us?
Hear you.
Okay, good.
And I'm following along on the PDF. So,
okay, good. Okay, good. So over the past 19 years, the Drugs Data Project has tested around 5,200 samples through GCMS, plus reagent tests that we do, different reagent tests depending on what the sample was suspected to be. And just as a reminder for everyone, we're not allowed to provide any quantitative results via the DEA. The DEA doesn't allow that. Our testing is conducted by our DEA licensed partner lab in Sacramento. We pay $150 per sample tested by the lab. Most of our samples historically have been submitted anonymously with the results published online with photos, but now we're doing a lot more work with some of the partner groups, and so those are submitted. We're still publishing the results in the same way, but there's a different stream of samples coming in. One of the questions that was listed was populations served to describe, and it made me think about it a little bit. But I think we serve a variety of different populations that are very different than most of the groups who are participating in this meeting here. Obviously the people who submit us a single sample for testing for our lab, who want to find out what it is that is in the drug that they are holding in their hand. But also people who are looking up a sample to see if it matches anything. People who don't submit a sample, but use our database to look up and try to match their own substance with our database. But also people who are tracking trends simply by browsing our published results. And now I think we're serving a sort of a different population through our partner groups, partnering with the ACDC groups.
So in 2019, we had a total of 573 samples that our lab tested and we published. And so far this year, we've done 420. And we're at the highest load of incoming samples we ever had. It's been a little bit, was a little bit weird at the start of the pandemic. Things were dropped a little bit, and it kind of screwed up our year. I don't wonder if it screwed up anyone else's year. But at the lab sort of didn't really ever shut down, but couldn't, had to change the number of people who were allowed in the room at the same time. And so we just as we got started with the partner groups sending things in was right as the lab was kind of figuring out how to handle stuff. And so we had a really kind of a horrible 5-week lag in May, and we're now recovered from that, we're pretty sure, and things seem to be moving along. But
so we have a pretty high testing load right now compared to usual. We just got 16 new results last night, and there's 10 more partner samples awaiting testing at the lab, and the lab has another 35 samples from the public awaiting testing. So they have a little bit of a backup. We're going a little slower than we normally do due to COVID-19 issues. So far in 2020, we've identified 122 different substances. 106 opioid samples have been tested so far in 2020. That's compared to 65 total in 2019. So we're obviously through the partner testing are doing a lot more testing of opioid heroin dope samples. In the past year, we've detected 50 substances for the first time ever. Not that we wouldn't have been able to test them before, but no samples had ever come in with those particular substances in them. And a lot of those are in the heroin and dope samples. Just things that, because we hadn't previously done heroin testing much, we hadn't ever had samples with all the weird opioid.
Or for phenylethyl 4A and PP.
Most of the fentanyl that we're seeing is in heroin and dope samples that we're doing the confirmatory testing on for the ACDC partner groups. We've tested 106 samples for partner groups in 2020. Fentanyl has been found in 75 total samples that we've tested. 69 of those 75 fentanyl samples with fentanyl in them are from partner groups. So most of those have been in heroin and dope samples. A few have been represented as cocaine. So we've had, through the partner group testing, we've had a bunch of samples with cocaine and fentanyl, but we're starting to think that those are just issues with cross-contamination of samples, that the fentanyl, because the fentanyl is detectable, because we're detecting such low levels of fentanyl. How would I describe that?
Well, if fentanyl were going to be the active drug, if cocaine were going to be the active drug, it would.
Yeah,
anyway, you don't want very much fentanyl in your cocaine. Yeah. if you're trying to get cocaine.
We think that mostly the samples we're seeing cocaine and fentanyl in. It's just cross contamination. It's hard to tell for sure, but for other fentanyloids, we've found only 2 samples in 2020 with acetylfentanyl, and then let's see, we had, and then the only other fentanyl-related substances in 2020 have been 4-ANPP and phenethyl 4-ANPP, which we think are precursors and impurities in the fentanyl synthesis process. On the non-opioid level, we're seeing a lot of flualprazolam sold in counterfeit alprazolam tablets, like a lot recently. As far as our LSD blotter testing, most of the blotter we're testing contains just LSD, which is nice, but it's probably the most of the substance types that we're testing. It's probably the most pure currently.
Because one of the things that's sort of interesting about the pandemic 2020 thing is, again, a big error message on the screen saying network problem. So I hope that you're hearing us.
We can still hear you.
Okay,
right.
Good, thanks.
Last year, if you talked about, the epidemic, people were talking about the opioid epidemic. And this year, that's, even though it seems like maybe the opioid epidemic is not getting better and might be getting worse, people from other groups can talk about that more. It's definitely kind of a weird, it's a little bit weird for me, just in my head, to try and figure out how to put this work in in context and sort of the general public. Anyway, so last year CDC offered this program to give out hundreds of new fentanyl analog reference standards for free if you went through an application process and all that. And we got the first set of those in January, and we got a second set of those, the Cayman set in July. But they came to our lab. We'll put up a picture somewhere. But they came to the lab in two huge grid boxes of unlabeled vials, where they were supposed to just
there was an index on a separate piece of paper.
And so the lab's having to spend an enormous amount of time going through and in order to add them as reference standards, you want
adding their own labels onto each vial so that they aren't getting mixed up in this giant box of vials, and then actually doing testing and making sure that each vial is in the correct spot to start with, because there's no reason to trust that.
We need to move on soon, so can you guys wrap it up, please?
We can.
Okay, good. So only other piece of data on my paper is that about 270,000 visitors view drugs data results online every month, and that's down slightly since the pandemic started due to pandemicness. That's it.
Thank you. Now I need to go back to the screen I'm sharing. Okay. Toronto's Drug Checking Services, coordinated by the Center on Policy Evaluation.
Awesome, thank you. Everyone can hear me okay?
Yep.
Oh, okay, good. Okay, hey everyone. Well, thanks so much for having us join this panel. This is my first time actually even learning about this group, so it's really awesome to hear what everyone's doing. My name's Karen, and I work at the Center on Drug Policy Evaluation, which is based out of Toronto. So we are coordinating a drug checking project, a pilot project here in Toronto. We launched in the fall, and we will be operating until about the end of 2022. So this service is funded by the federal government here in Canada, and then we also have received some donor funding through the foundation at the hospital that we operate out of. Next slide, please. So in terms of our population served, our population would be just kind of people who use drugs in Toronto broadly, although we're specifically hoping to reach those at highest risk of opioid overdose. We are also receiving a lot of samples from harm reduction staff. So perhaps someone, perhaps a client was using at the SCS, at the supervised consumption site, and overdosed, and their cooker was left behind on the bench, and the frontline staff might submit that on their behalf. So we offer collection of samples and communication of results at 5 of Toronto's harm reduction agencies that offer supervised consumption, as I mentioned, and samples could include a small amount of an actual substance or paraphernalia after it's been used, as is shown on this slide here. So in terms of sample size for an actual substance, we're asking for up to 10 milligrams. So it kind of depends what a client's willing to or has left to give up, but we're asking for 10 if possible. So samples are then picked up from the harm reduction agencies 5 days per week and transported by bike courier to one of 2 nearby clinical labs, where they're then analyzed using gas chromatography or high resolution liquid chromatography mass spectrometry. We're getting results back to clients within a day or 2. And results are communicated by harm reduction staff and accompanied by tailored harm reduction strategies, providing the client wants that. Next slide, please. So in terms of what we're seeing, we've checked over 900 samples since we formally launched last fall. The data presented on this slide is actually just goes up to mid-July. So the majority of samples that we've checked have been opioids. However, we are also checking a variety of other stimulants and psychedelics and depressants. But seeing that my time is limited, I thought I would focus on samples that were expected to be fentanyl today. So I totally appreciate that there's kind of a bit going on this graph, but essentially what we're trying to show you is the presence of fentanyl and then what we call unexpected noteworthy drugs in 364 expected fentanyl samples. So as indicated on the slide, we define noteworthy drugs as drugs that are either highly potent or are linked to overdose or other adverse effects, or drugs that may not be desired by clients. So the peach line that's at the very top represents fentanyl found in expected fentanyl samples. So as you can see, fentanyl is not always present. In fact, 7% of the fentanyl samples that we check contain no fentanyl whatsoever. 88% of fentanyl samples contain fentanyl and other drugs. So the most commonly found drug that we are seeing here in Toronto alongside fentanyl is caffeine. It's actually not represented on this slide, but caffeine is presenting in 81% of all fentanyl samples, and in the largest proportion of the drugs found as well. So it's definitely like the most prominent drug. In terms of unexpected noteworthy drugs, then I'll kind of just start working down the list, but jump around a little bit. So we're finding several fentanyl-related drugs, both active and inactive. So the blue line that you'll see represents inactive fentanyl-related drugs, which are presenting in about 50% of fentanyl samples. So this includes despropanol fentanyl, or 4-AMPP, which is the impurity found in fentanyl preparations, as well as other drugs like fentanyl hydroxy and then variations of norfentanyl. The purple line, which is sort of closer to the bottom, that represents active fentanyl-related drugs that we're finding, and they're presenting in about 6% of expected fentanyl samples. So that includes acetyl fentanyl primarily, and also carfentanil we see a lot less frequently, but we see it in about 1% of fentanyl samples. The yellow line then is benzodiazepine-related drugs. So they are presenting in close to 40% of all expected fentanyl samples that we're checking. Primarily it's atizolam that we're seeing, but we're also seeing a fair amount of fluoprazolam, Xanax, and flubromazolam. And then the dark dark pink line, that's phenacetin, which Abby was referring to. It's the kind of off-market pain relieving, fever reducing medication, which is a known filler in cocaine, but we're actually seeing it quite a bit in fentanyl as well. So it's presenting in about 11% of our samples. And then the turquoise line closer to the bottom is Furanil UF17. So this is a drug that we can't find out much info about, but it's an opioid-related drug with unknown potency and effects, and it's presenting in 7% of fentanyl samples. And then lastly is the green line, which is synthetic cannabinoid-related drugs. So we're seeing those present in about 4% of our expected fentanyl samples. And this includes Ambifubanaca and also more recently Acmanaca. So these drugs are very potent and not expected by people who are using fentanyl. And when used in combination with opioids, they can increase the risk of dangerous suppression, to vitals. So that's why we kind of call those out. So in terms of kind of fentanyl contamination in other drugs, we're hearing in Toronto that, people who are using crack are experiencing opioid overdoses, but it's not something that we're actually seeing in the samples that we've checked. But certainly fentanyl is presenting in other opioid samples. So like, for example, 40% of the expected heroin samples that we check contain fentanyl. Next slide. Thanks. Okay, so in terms of takeaways, we've certainly learned a ton of lessons, even though we're pretty early into implementation. So I just kind of listed a bit of a brain dump on the slide here. So first I said the importance of creating strong relationships with clients and the harm reduction community at large, and of course with those who contribute to the operation of the service. This is especially important for a project like ours that is like multi-site, multi-sectoral. Second is to harmonize and simplify processes. So a lot of the heavy lifting for our project is undertaken by harm reduction staff, like the collection and the communication of results. And these are individuals who have very demanding jobs, and often the organizations are under-resourced. So we've tried to really work closely with harm reduction staff to develop the processes, and also to make sure they're just as straightforward as possible and kind of consistent across all of the sites. Which kind of connects nicely to my next point, which is about iterating based on feedback. So since we're a pilot project, we kind of are set up to do drug checking in one way, but our plan is to be changing throughout the next kind of 3 years. So we're constantly collecting feedback from clients and from those operating the service so that we can ensure that we're offering the best service we can and meeting the needs of the population. Next is sharing timely information. So as I mentioned, we're communicating results directly back to clients, but we're also every other week, we're combining results from the samples that we've checked, and then we're feeding those back to the community of people who use drugs and people who care for people who use drugs. So just to keep everyone in the know. So we're developing a website that we hope to launch within the next couple of weeks to make this information more kind of easily accessible. And hopefully we'll be in a position where we can actually share information more frequently. We just want to commit to every 2 weeks at first. Okay, and then quickly, my last 2 points are just related to information you're providing to clients. So a couple things we've learned: if possible, provide quantitative information, as it can help clients to understand their tolerance and compare their results across samples, and also make dosing decisions. So of course there are technological limitations that make determining quantitative information challenging, but what we've learned is the more quantitative info you can provide, the better. And then lastly, if possible, to provide information about non-drug fillers. So our service is set up only to report drugs that are found in samples, And as we are starting to quantify drugs found, we're realizing just how small the amount of drug is in any given sample. So, not reporting the drug fillers piece is actually creating a pretty big gap for our clients. And, non-drug fillers, of course, can be harmful too. So if it's possible to report those, definitely do it. So that kind of concludes my overview. I know there was a ton of info. Our website is cdpe.org if you want to learn more or get in touch with me. And thank you very much.
Thank you. Okay, now for the rest of the time, Vancouver Island Drug Checking Project, an introduction. Y'all are up.
Hi, my name is Bruce Wallace, and I'm going to be presenting on the Vancouver Island Drug Checking Project. I am up at University of Victoria, where I'm a scientist with the Canadian Institute for Substance Use Research and also a social work prof. And initiated this project with Dennis Hoare at University of Victoria, Chemistry and Computer Science, and I'm presenting this on behalf of our UVic Drug Checking Project team. I want to acknowledge, first of all, that we are on the Kwangkan territory. Vancouver Island's in the Salish Sea, so on Coast Salish territory, and also recognize that our project was initiated as part of the overdose crisis response, but we follow over 20 years of history of drug checking in this region as a grassroots and as a harm reduction movement, especially those folks on the phone and others who do drug checking at Shambhala. Can we move to the next slide, please? So we're doing community drug checking as sort of a different than the festival and event drug checking. Again, responding to the overdose crisis in British Columbia, we have a public health emergency that was declared 5 years ago and continues here. We're providing direct service every weekday in Victoria, BC. Which is the capital city on Vancouver Island. And so, as I mentioned, we're combining, the project's trying to combine social work with chemistry with computer science. So it was initiated, we're trying to basically get academic grants to be able to do drug checking in community. And so just continually applying for grants as pilot projects and as research to be able to fund drug checking. And so in that way, it combines science with harm reduction. So some of the science is that the project is designed to try to answer some of the questions around science, around spectrometry and around the chemical analysis and how to improve science. And then it's actually direct harm reduction, which is my background in providing harm reduction service, but also how to engage drug checking in some of the harm reduction that has been in communities, such as needle exchange, overdose prevention sites, and opioid substitution therapies, safe supply, and decriminalization, all those sort of things. How does drug checking fit within that movement? And so in that way, it's just a mixture of service and research, which is sort of good and sort of bad. We need research ethics to be able to go do this. We have ethics approval, which is challenging when we're trying to also be really responsive as a service. But it's also a strength. All the samples that we get, we give information back to the people who bring us samples, but we're also using the research, the data, the samples provide data that we can actually then also be doing research. So the technologies, we're using the test strips, fentanyl test strips is what we started, and then we're also using benzo strips for the down samples, opioid samples. We're using an Agilent FTIR and a Raman instrument, and then also a Raman SIRS. The SIRS is for surface enhanced Raman scattering, and then a portable GCMS. And so this is part of our research project as we're looking at the different technologies. And so every sample goes through the different instruments and all the data is collected, and we're basically still trying to find out what are the limitations and the benefits of the different instruments for drug checking within an overdose response. And then other research and reporting. So just on the side there, the graphic is one of our monthly reports, or that's the year-end report that we put out for public health. We do qualitative interviews with people who use drugs to try to to try to get more information about how to implement. We're using implementation science as one of our methodologies to figure out how to move forward with drug checking. And then finally, trying to work towards some sustainability. It's a pilot project, as many of the projects are that have been funded in the overdose response. So how do we get technician training and harm reduction training? How do we build the capacity and the sustained funding for these projects to continue? All right, last slide, please. So we were asked to talk about the takeaways messages. And so here's a list that we sort of have. And the graphics are just some of the instruments that are in our project. So first of all, drug checking has this great role around destigmatizing drugs and increasing conversations and information about drugs. And that's also, I think, unique from some of the existing harm reduction in community around, especially injection and inhalation drug use, like needle exchange and such. It's a different form of harm reduction when the drugs are put on the table and we actually get to discuss and get more information about them.
My phone.
Brandy, Lydia, your audio's on.
Yep, I was just telling Lydia that.
Okay, I'll try to be fast. Drug checking isn't just about the unexpected results or bad drugs. It's also really valuable to when we talk about confirming that people have the drug that they're wanting to purchase or use or sell. We're really interested in working with people who are supplying drugs and the potential role of drug checking and selling. And we continue to try to work in different ways to make sure that happens. We are concerned always about how we're not accessing some of the populations that are really being impacted by opioid overdose, by fentanyl overdose, and how to make sure that drug checking can be an appropriate service for the diverse populations of people who use drugs. And we're still finding that the instruments are limited. There's all kinds of benefits to the instruments, but then how do we make sure that each instrument is actually providing really useful results for the person who is going to be using or selling the substance? The context to criminalization is massive. So providing drug checking in criminalization, it impacts the people who want to access the service. It impacts how we can deliver the service, and it really limits our research. And we want to always make sure that we're advocating and engaging in safe supply, and decriminalization is part of drug checking's mandate. And just a really one sentence that's really massive is who and how and where we provide services really matters. Who's providing the service? That people who use drugs and know drugs are providing the service. How we provide the services in a harm reduction mandate and where we are, that really makes a difference. And that is it. Over to Jaime.
Jaime, thank you so much. And please do your thing and take your time.
Thank you so much. I'm going to be trying to be really fast. Hopefully you can hear me really well. So I'm going to talk from two organizations that I'm working in. I'm Jaime Redondo, professor of drug policy at CIDE and also a researcher with BCCSU. But I work with two border organizations in the city of Tijuana, with Provencasa, and also in Mexicali, Verter. So first we started our drug checking in the summer of 2018, and it was really because one of our clients reported that the substance that they were using, it was extremely strong. So that gave us some suspicion that maybe we had to start testing for fentanyl. At the moment, we were doing some research related to people who use drugs and the introduction of fentanyl into the city, and the surveys were coming out with all negative references to fentanyl. So after that first report, we started a small pilot or research project, a little bit similar to what Bruce's team has been doing, in the sense that we wanted to tie it up service provision with fentanyl testing. So what we did was using paraphernalia or paper wrappings to understand if there was presence of fentanyl, at least manufactured fentanyl in the drug supply. We use the service with people who either comes to our fixed site or through our mobile outreach. And the idea was to try to identify hotspots for increased risk overdose. Right now, we have been given a little more money to create a new research project, and the idea is to create a new sample mechanism where we can take out several substances, not only opiates, but also stimulants. Following that one, with our sister organization in the city of Mexicali, which I don't know if many of you know the border, is 2 hours east of Tijuana, right across Calexico. We started seeing also some reports of people saying that the drug supply was extremely strong. And the director of the organization thought it was a good idea to follow up what we had been looking in Tijuana, and we started doing some testings in summer 2019. The project there is a little bit different. It's part of our, we have a safe consumption site, is the first and only one in Latin America. The service is also only for women. So what we do is we have the test available so the women can use it right before they come into our space and start using their substances. We, in some occasions, can provide the fentanyl testing strips if they want them to go. This is something that we don't do in Tijuana, and I will explain a little bit why that is. Can I have the next slide, please? So some early results in Tijuana, which is where we have really done more systematic analysis, and we published a paper on it. We did close to 100 samples throughout almost 6 months. It was mostly through the end of 2018, but all the way till the summer 2019. And we were focusing too much on China-wide because we were doing it in a partnership with the National Institute of Psychiatry, and they were really interested more in China-wide. I insisted that we had other substances. And after we finished those results, we saw that the majority of the powder, all of it was positive for fentanyl, and the tar came negative. So if you see in the pictures there, we will get the sample, dissolve it in water, you know the process, and then we will keep in a baggie the result, and then we record when it was done, what type of substance, where did I got it, and try to get a record of it. However, after we did the pilot, unfortunately, we started hearing more anecdotes from our clients about the tar, the black tar being extremely strong. So that led our field team from the harm reduction side of the organization to start making fentanyl testing strips more into tar. And to my disbelief, and I think other people who came with me to visit in Tijuana, we started seeing fentanyl positive tests in the black tar. Even though that we knew that it was possible, we knew also it was not as common. Unfortunately, COVID has, as many of other projects, delayed our follow-up project. We hope that we were able to start this summer, but we are still waiting for the funding money from the NIH so we can continue with doing the testing. In Mexicali, we have done roughly now over 100 tests of every use, almost every use that comes into the safe consumption site. We don't mandate it, but we ask people if they want to have certainty about what they use to have the test done. And even though it was rare at the beginning, we have now seen more of a positive trend towards fentanyl testing strips in black tar. And now the ones that we find are almost 80% positive from the substance that the people bring into the service. Next slide, please. Some key takeaways that I want to give you all or share with all of you. We faced several structural barriers. First of all, is how to disseminate the results in a high violence area. So Tijuana had, for example, almost 2,500 homicides the last year. And we are in a red light district and in a place where we have many of the selling points in the city. So literally, we are a little bit sometimes scared of trying to make these results public because of what consequences it might have for organizations. So we are trying to understand how to better engage with suppliers so they don't see us as something of a bad publicity for them. The other big problem, fentanyl testing strips are not available in Mexico. And when we had tried to mail them from the US or Canada, they have been confiscated by Mexican immigration and customs. We tried to send some from Tijuana to Mexico City. It was such an ordeal. I ended up sending 10 hidden in a book. And our partner in Mexico City did these fentanyl testing strips and also found positive results in the drug supply in Mexico City. I was able also to send them a couple of benzo strips, and some of them came out positive as well. So this indicates that the markets are changing, that the black tar is being mixed with fentanyl even more now. And then it becomes more difficult for people to try to shift drug supplies to reduce their harm. For example, in our safe consumption site, women try to avoid the places where they know they have fentanyl, but now it's becoming more difficult. And finally, how can we recapture the message? So with this article that we published, the government then decided to create this campaign that you see there in the bottom, which says fentanyl kills. But it's not really the fentanyl that kills, but it's the lack of action of the government of having no naloxone available that kills. So we need to link our data so we can press better for naloxone distribution in our countries and our communities. So if you have any questions, happy to solve them later on the email. And thank you so much for the time.
I'm what? Unmuted.
Yep, that's it. That was all. It was 7.5 minutes. I think I just perfect on time.
That was amazing. Thank you for being on time. We are technically over the time. There are some unanswered questions. Tracy Lynn would like to know if we can provide article citations. So I'm not sure if there is information coming out afterwards, but we will try to figure out a system or a repository way that people can access information related to this session today. And Lydia, do you have thoughts on questions? Okay, so it looks like all the questions are answered. And since we're 10 minutes over, I want to thank everyone for coming today. Is there any last thoughts or comments? All right.
No, just thank you everyone to share.
Yeah, I thought it was really great. Thank you.
Earth,
and we'll
I
see
can
you.
finally see your video.
Yeah, Earth, we can see you. Oh, you're muted
Can't
now.
hear you.
Hear you.
Oh, wait, now I'm not. I bet I'm not muted now.
Yeah, we can hear you now.
Yeah.
And we can see you.
I can't get it working on my machine over there, so I'm
Yeah.
standing behind him.
Yeah, we just keep rebooting Chrome every couple minutes. You know, that seems to be.
Oh my God,
the
Earth and Fire! I don't think I've actually seen your faces in I can't remember when. So.
Howdy.
Hello, everyone.
Hi. All right. It was lovely to see all of you, and hopefully we'll see each other randomly throughout this week. Bye. Thank you all.
Thank you.
Bye, everyone.
I thought so.